The following talk was given during the January 2021 staff meeting and was intended specifically for AirMed flight crews. Please consult your own agency's policies and procedures when managing these types of patients.
Okay, so we're going to bring our new education plan full circle. One of the topics identified as high yield by our crews was more ventilator management. And as we saw reviewing the charts for this month's CQI, we saw a number of our crews transporting patients with really complicated ventilator management because of severe COVID ARDS. And the crews have uniformly done a great job with this, but it's certainly a topic that's worth sharing with you guys because holy cow, some of these folks are really difficult to oxygenate. So here's a quick little PowerPoint that we can go through and hopefully give you guys some good information on good vent management for these folks with severe ARDS, whether it's from COVID or something else. So a few basic concepts here. First off, hypoxia is typically caused by VQ mismatching. And just to review, V is ventilation, so where's the air going in and out of your lungs, and Q is flow or cardiac output, where's the blood flow going. So something like the obvious example is a main stem intubation. There's blood flow going to one of your lungs, but no air going to one of your lungs. So that's a VQ mismatch. Other very common etiologies of VQ mismatching are atelectasis, which almost all of our patients have. I mean, all of you guys have some atelectasis. Everybody has some atelectasis, but VQ mismatching is very, very commonly significantly compromised by atelectasis. We'll talk some more about that in a second. Increased lung water is another primary etiology of VQ mismatching, and that's what's at fault with pulmonary edema and ARDS and pulmonary contusion. There's just so much lung water in there that it interferes between with diffusion from alveoli into the capillary beds. And then other common ones that you're all familiar with are going to be main stem intubations, a pulmonary embolism where there's no blood flow to part of the lung that's being ventilated, pneumonia where part of the lung is full of pus and there's no airflow into it. A bronchial obstruction like mucus from pneumonia would be another common etiology of severe VQ mismatching. Pneumothorax would be another one. And then lung scar, one unfortunately we can't do much about, things like idiopathic pulmonary fibrosis, asbestosis, sarcoidosis, coal miners' lungs, those are all lung scar. Other etiologies of VQ mismatching, less common, but something else to be aware of is shunt. Like you have an ASD or a VSD and you have blood flow that's shunting from the right side of your heart to the left side of your heart and bypassing your lungs. And then high altitude and low FiO2 or other possible etiologies of hypoxia. But the vast majority of it is going to be VQ mismatching. In contrast, hypercarbia is typically caused by low minute ventilation, either low respiratory rate or low tidal volume. And note that tidal volume is going to be effective alveolar tidal volume. And when you're using a ventilator, part of the tidal volume you deliver is dead space tidal volume, not effective alveolar tidal volume. That dead space tidal volume is the volume of gas in the circuit that's going back and forth, but never getting to the patient. And with a ventilator circuit, that's about 150 mLs. So if you have an 800 ml tidal volume, the effective alveolar minute or tidal volume is 650. It's a lot. But think about it, if you have a 250 ml tidal volume, 150 mLs of that is just dead space ventilation. So your alveolar tidal volume is really small. You have a lot of dead space ventilation. That's really going to contribute to hypercarbia. VQ mismatch doesn't have much effect with hypoventilation and hypercarbia, but it does have a little bit. Next slide, please. So atelectasis, yeah, these are all of our patients. Obesity, immobility causes atelectasis. Hypoventilation because of altered mental status or drugs cause atelectasis. And positive pressure ventilation causes atelectasis because we don't use as big a tidal volumes as you and I do when we're walking around the house, because positive pressure ventilation also causes barotrauma and acute lung injury. So to minimize acute lung injury, we use smaller tidal volumes than you and I do walking around the house or running up and down the street. But the result of that is you get atelectasis and VQ mismatching from it. And the smaller your tidal volumes that you use, the more atelectasis that you're going to have. Obviously, sitting patients up is going to help their atelectasis. It helps it a lot. And Peep and recruitment maneuvers improve atelectasis. Recruitment maneuvers are the primary strategy, other than sitting somebody up, to manage atelectasis. And the way to do a recruitment maneuver is use your BVM, set the Peep valve at 20, and then give the patient a big breath. Use your manometer on the BVM. Give them a big breath to 30 centimeters of water pressure on the PIP valve and hold it for 20 seconds. You won't be able to do this on somebody that's not heavily sedated or paralyzed because they won't tolerate it, and it may tank their blood pressure for a few seconds, but it really recruits a bunch of atelectasis. If you do that 2 or 3 times, you can often get a big improvement in oxygenation just by reducing atelectasis. Next, as we mentioned, positive pressure ventilation also causes lung injury. And the primary culprit for this seems to be, as we're figuring out in the last couple of years, driving pressure. Driving pressure we can measure as delta P, delta pressure, the difference between PEEP and P-plat. So that's your driving pressure. And delta P's greater than 16 seem to be a really significant threshold for causing acute lung injury from positive pressure ventilation. So as you look at your vent settings, if you've got a PEEP of 5 and a peak inspiratory pressure of 20, that's a delta P of 15, you're not causing significant lung injury with that. But when you've got a delta P of 30, that's tearing lungs apart. And we're probably causing more lung injury to folks than we've realized in the past. Big tidal volumes are a modest contributor to acute lung injury. Not very much, it appears, as long as the delta pressure is low. Probably all of us could tolerate 10 ml tidal volumes with really low delta pressures, but bigger tidal volumes do increase lung injuries. That's why we try to limit tidal volumes at 8 mLs per kilo of ideal body weight. Note that high PEEP or high PIP are not particularly harmful as long as the delta pressure is not that high. It's the change in pressure with each breath that tears alveoli. It's not just high pressure, it's the change in pressure between the inspiratory and expiratory cycle. So raising the PEEP decreases delta pressure and decreases acute lung injury. These protective ventilation strategies that we've been talking about have a big impact on reducing acute lung injury from the ventilator. So you guys are all familiar with this. I'm going to breeze through it. These are our basic vent settings: PEEP 5, IDE ratio 1:2, respiratory rate titrated to your Untitled 30 to 35, and use 8 mLs per kilo body weight as long as the delta pressure or the PIP are reasonable. Don't worry about it. Those are going to be fine ventilator settings. Just adjust your respiratory rate to get to our ideal end-tidal CO2. Next slide. Causes of high pressures. So obviously sick lungs are part of it. And we're going to go into these again in a second, but these are the rule outs. Every time you've got either high pressures or hypoxia, please go through these rule outs. Make sure they don't have a pneumothorax. Make sure their stomach is drained. Make sure they don't have a main stem intubation. Make sure their endotracheal tube is clear, it's not kinked, and run a suction catheter down it to make sure there's not a mucus plug in it. And then make sure they're not bucking the ventilator. And patients may look calm and still be bucking the ventilator. Go back a slide, please. Patients may look calm and still have high intrathoracic pressure because they're making some respiratory effort. So increasing their sedation or paralyzing them can take care of that. And I encourage you to just be really liberal, especially with the opioids and paralysis. If you've got high airway pressures or hypoxia, just paralyze them, make sure they're adequately sedated to take that out. Okay, next slide. Super quick review for the Marlboro Man. God, I wish I looked as good as that guy. I think the horse wants to kiss him. He looks so good. Obstructive lung disease. Remember, this is asthma with an acute exacerbation and COPD, and rarely these other things, cystic fibrosis and remote barotrauma, whether it's a ex-preemie neonate that was on a ventilator for a long time with bronchopleural dysplasia, BPD, or ARDS with high vent pressures causes acute lung injury, barotrauma, tears the bronchioles apart, and this will eventually, long-term down the road, result in obstructive lung disease. Next slide, please. So remember, obstructive lung disease is hard to get air out. Chest x-rays look like this because you can't exhale all the way. And like all sick lungs, I encourage you to use pressure control or PRVC mode. You can still use a reasonable tidal volume most of the time with these folks. The primary strategy is just using longer expiratory time, 1:3 IDE ratio instead of our baseline 1:2 IDE ratio. So longer time to get the air out. Peep 12 and respiratory rate titrated to end-tidal CO2 at 35. And for these cases, and really with everybody, think of max respiratory rate of 25. Next slide, please. Then restrictive lung restrictive lung disease. Yeah, the American waistline and ARDS and all of these other problems that lots of our patients have. Primarily, these are lung problems, but they can also be pleural problems, like air in the pleura makes the lungs stiff, hard to air get in. Big pleural effusions makes the lungs stiff, hard to get air in. Scoliosis with their rib cage all corkscrewed down makes it hard to get air in. Pregnancy, obesity, ascites, pushing the diaphragm up, hard to get air in. And burn eschar makes the whole chest wall stiff, hard to get air in. Restrictive lung disease is hard to get air in, results in the chest x-rays that look like this because you just can't get the air in the chest. So the basic vent settings that are going to work for most patients, like our 300-pounder from Rock Springs that's got pneumonia, this is going to work just fine for him. Set the vent and pressure control, higher PEEP, because these are going to be folks that are hard to oxygenate because they have a lot of VQ mismatch. So start with a PEEP, something like 8 to 12. Longer I time, so longer time to get the air in, and you're probably going to need to use a smaller tidal volume because you just won't be able to get that much air in without causing really high pressures. And then titrate the end-tidal CO2 to your, titrate the respiratory rate to your end-tidal CO2. Next slide, please. So what about if you don't know? So you've got the guy with ARDS that's a smoker, or the COPD guy that's now got a CHF exacerbation. Should you use restrictive vent settings or obstructive? I don't know. And you don't know until you do some trial and error. So start out with your ID ratio 1:2, your normal settings, and see what you get for pressures and volume. And then change your ID ratio to 1:1 and see if that works better or worse, depending on whether you're using pressure control or PRVC. And compare that to using 1:3, and whichever one gives you the biggest tidal volumes or the lowest pressures, that's what you should use for this patient. So it's really hard to tell sometimes based on history. Use trial and error. If they're still hypoxic, go through those rule outs again. Make sure they're not main stem, don't have a pneumothorax, stomach's decompressed, they're paralyzed and adequately sedated. Obviously, make sure they're sitting up when the FiO2 is 100%. Use that recruitment maneuver and bump the PEEP up. Next slide, please. Permissive hypercapnia and breath stacking are important considerations with these patients that are increasingly hard to manage their ventilator. So if you are getting high pressures despite the ventilator optimized as well as you can, high pressures are worse, or sorry, high pressures are worse than high CO2s. High CO2s go away when their acute problem goes away, but high pressures, high delta P doesn't go away because you're tearing their lung apart. So first off, let their CO2 get high. CO2s in the 50s and 60s are totally, arterial CO2s in the 50s and 60s are totally fine, except they're uncomfortable. So patients are going to try to overbreathe, and you don't want them to be overbreathing if they're this hard to ventilate or oxygenate. Make sure they're paralyzed and sedated well enough so they're not trying to overbreathe and buck in the ventilator. And for some of these folks with really bad ARDS, like we're seeing with some of these COVID ARDSs, if you've got a choice of PIPs of 50 or a delta P of 30 or 40, leaving their arterial CO2 at 80 or 90 or even 100 may be better than tearing their lungs apart. This is what permissive hypercapnia is about. Let their CO2s go high. That's not going to kill them. Tearing their lungs apart will. Next concept, especially with these short E times, these 1-to-1 IDE ratios, is some of these folks are going to breath stack. And this is just incomplete expiration. So the patient is still expiring when the ventilator starts the next breath. And they're still expiring after that breath when the ventilator starts the next breath. So they keep stacking breaths one on top of each other. And primary risk factors of this are going to be smokers or ex-smokers. Older patients are more prone to breath stacking. 20-year-olds don't breath stack unless they're having an asthma exacerbation. But high respiratory rates and short E times, these 1-to-1 IDE ratios like we use for ARDS, these can definitely cause breath stacking. And breath stacking looks like a tension pneumothorax with really high pressures and hard to get adequate min ventilation. Their CO2 is going up and up and up and up because you can't get big enough tidal volumes. And it's like a tension pneumothorax because their intrathoracic pressure is so high that their venous return is compromised and their blood pressure and cardiac output are going to be low. Next slide, please. So how do you diagnose breath stacking and what do you do about it? Warning signs are going to be that shark fin CO2 waveform and unexpectedly high PIPs and low VTs, and those risk factors, older patients or patients with COPD that you're trying to use 1-to-1 IDE ratios on them. Next time you're in the ICU, and especially you nurses while you're in the COVID unit doing your rotations up there, get the RTs to show you the flow volume loops and show you how they diagnose breath stacking on the ventilator. That's a tool that we can use if we go into another hospital, into another ICU, and they're on a ventilator, and you're worried about breath stacking. The primary therapy for breath stacking is to just reduce the respiratory rate. It's obviously going to let the CO2 rise higher. That's permissive hypercapnia, but it will let you oxygenate them better. The other thing you can do is go back to a little longer expiratory time. So maybe they need a 1-to-2 IE ratio, not 1-to-1. And then if they've got COPD or asthma, consider using albuterol and ipratropium to bronchodilate them a little bit. Okay, let's do a case presentation and we'll carry it through for these really hard to oxygenate COVID ARDS patients. So you go into the ICU in wherever, Rock Springs, and they've got a COVID patient. He's been intubated for a couple days. We've finally gotten a bed for him at the university, but he's already on really high pressures with a peak inspiratory pressure of 40 and 15 a Peep. That's giving you 6 mLs per kilo of tidal volume. They've got the ID of 1-to-1, respiratory rates as high as they'll go, 100% FiO2, and his SAT's 80%, and his end tidal CO2 is 60. First off, is that okay? It may be, it may be as good as you're going to get without tearing his lungs apart. And if you go through all the rule outs and don't get any better SAT and lower pressures or better ventilation with lower CO2 than that, that's probably going to be okay. And it may be better to transport him with the sat in the 80s, even the low 80s, than to use even higher pressure and tear his lungs apart. So these are reasonable numbers as long as you've gone through the rule outs and you're using appropriate vent setting and you don't think they're breath stacking. This is okay numbers. Sats in the 80s are okay, better than tearing their lungs apart. Next slide, please. Next, okay, good. So let's make him a little worse. And we've had a few of these in the last month that we've transported. You go into the ICU and this guy has got vent pressures of a PIP of 45 and 18 a PEEP. So he's got a really high delta P already, and that's still only giving you a 5 ml per kilo tidal volume, even with that 1-to-1 IDE ratio, high respiratory rate, 100% FiO2. And he's at 70%, and his end tidal CO2 is 90. Well, is that enough to live with? It's probably enough to live with. But please at least make sure you go through the rule outs and there's not something that you can easily make better without hurting him any more than that. And I think a primary strategy for this guy is bump his PEEP up to the highest you can use. And I'm gonna put the highest PEEP we should be using at 20. What if you've got, go ahead, next slide. What if he's got pressures of 50 over 20 and you still have those numbers? Now what? And we're seeing these kind of vent pressures, inspiratory pressure of 50 with a PEEP of 20, and they're still hypoxic or worse, or they've got an arterial CO2 of 120 on their blood gas. So our ICU docs don't want to be our medical control, but they may have valuable input on these folks. And transporting folks with this kind of situation after you've gone through all the rule outs, this is really high risk that they're either going to have cardiovascular collapse or their oxygenation is going to get even worse in transport. There's a really high risk these folks are not going to survive a transport. So please get medical control on the phone and get the flight center to try and get the receiving ICU attending on the phone. Or if you can't do that, try and get me on the phone. Let us help you work through, is there anything else we can possibly do? Couple of things to consider, although there's obviously risk with these things. One is using inverse ratio ventilation. So especially for younger folks or non-smokers, by using an IDE ratio of 2-to-1 instead of 1-to-2, you have a longer percentage of each breath that lung is completely inflated and may get a little better oxygenation with this inverse ratio ventilation. But there's significant risk of breath stacking. So you really got to be careful using these inverse ratio ventilation. This is probably somebody that's already been proned because the knowledge is out there and the literature has been out there, and hopefully the docs managing these folks at other hospitals should know about it, and they will have tried it already on this patient. He may already be proned when you get there, but if they haven't tried proning him yet, this is somebody that maybe you should consider proning and see if that improves their oxygenation. And then what about VV Ecmo? Holy cow, this is a challenging topic. And unfortunately, the hospital, even with inpatients, has been put in the difficult situation of having to severely limit the patients we consider for VV Ecmo because we just don't have primarily the nursing staff to manage them, because our nursing staff, and you guys are well aware, is already stretched so thin covering all these extra intensive care unit patients. And getting the resources to go out right now and cannulate somebody for VV Ecmo, this is going to be a big stretch, but it's something to talk to medical control about. If you've got a patient that's so hypoxic and so hard to ventilate that you don't think they're going to survive a transport, talk to medical control. Let's get the receiving attending on the phone and see if maybe VV Ecmo is a something we could consider for this patient before we put him in the aircraft and kill him. All right, last topic I want to go through is ARDS and high vent pressures and shock, because this is another one of the complicators of these really, really high vent pressures and severe ARDS. The current trend for all ARDS, and in particular for COVID ARDS, is to run these patients really dry to reduce lung water, to oxygenate them a little bit better. And some of these folks are going to be over dehydrated into the point that they're in hypovolemic shock. And not only does that put them in shock and kill their kidney and their gut, but it also worsens their oxygenation. So think about this in the context of VQ matching. The Q is perfusion. Perfusion is cardiac output. If patients are dehydrated enough that their cardiac output is falling, the percentage of their lung that's getting flow from cardiac output is reduced. That worsens VQ matching and worsens hypoxia. So it is possible for these folks to be dehydrated enough to compromise their oxygenation. And in fact, I saw a patient like this I transported out of Mountain Point last year. This guy it was not COVID, but he had severe ARDS, and the intensivist there had been dehydrating him enough that he was on norepinephrine to maintain his blood pressure. And I looked at his IVC with the ultrasound, and his IVC was empty, despite his lungs being hyperinflated with high intrathoracic pressure, which should be distending his IVC. So he was in hypovolemic shock, and his urine output had fallen off, and his oxygenation was poor. And we gave him 250 mLs of albumin and turned off his norepinephrine, and his blood pressure got better, and his SAT came up 4 points just because we increased his cardiac output. So consider this as a possibility with these folks when you're looking at them, especially if they're hypotensive or they've got rising creatinine, or especially if they've got metabolic acidosis and elevated lactate on a blood gas. These folks are in shock, either because of the high vent pressures causing right heart failure, or because they've been dehydrated, or they're so sick they're not getting adequately hydrated into hypovolemic shock. These folks, all of these folks with high vent pressures should have high CVPs and dilated IVCs. If they do not, they are not getting adequate venous return to push that blood past their high intrathoracic pressure to get it into their heart. If they don't have a CVP higher than 10, probably needs to be 15 plus actually. And if they don't have a dilated IVC on your ultrasound exam, they need volume, and actually giving them volume will increase their cardiac output and improve their VQ matching and their oxygenation. But don't give them crystalloid. They should get either albumin, 5% albumin, we don't carry it, but every hospital I think is going to have it, or give them packed cells if their hematocrit is low. And then the last couple things, if they're hypotensive and their IVC is full, they may be either right heart failure, or maybe they've got a component of sepsis, and I would start those folks on a norepinephrine infusion to get their blood pressure up, to perfuse their right heart better, as well as perfuse the rest of their body better. And if they're in shock with their IVC full, like they're in shock with metabolic acidosis and elevated lactate, and their IVC is full or their CVP is high, think about starting an inotrope infusion on them as well. And I see Amanda noted plasma is a good colloid to use as well. Yeah, I'll agree with that. Not crystalloid, use albumin, or consider using FFP. This is not trauma. We shouldn't be using our blood for this. I won't say can't. Or use packed cells if your hematocrit's low. So I'm going to go through these. There's a bunch of comments here I haven't had a chance to look through yet. So Jason Ferriman mentioned Flowland. So that's a great topic. I'm glad you brought that up, Jason. So Flolan vasodilates the capillary bed around the capillaries that are being ventilated. And it has, my experience is that it has a very modest improvement for VQ matching, but it does improve VQ matching. So Flolan may be something to consider for these folks as well. And certainly if they're already on Flolan, we need to get RT there to set up Flolan for us. Absolutely use our RTs. They're really good with this stuff. They're doing it every day in our intensive care units right now. Lung sounds help at all with obstructive to restrictive disease if you don't have a chest x-ray. Absolutely. If you've got expiratory wheezes, that's going to be consistent with obstructive disease. Lung sounds for restrictive disease, typically just going to be decreased lung sounds, but that could also be from breath stacking. So lungs, you know, none of the tools we have are perfect, but the more information that you get, the better, the more information, the better, and the better able you're going to be able to make a good decision about this. And I see a couple of, can I get a copy of this PowerPoint? I'll tell you what, I'm going to send this PowerPoint to Jason Cook, and he can send it out to the rest of you guys. And let's see what else in the chat there. Speak up if somebody's got a question I haven't addressed already. Oh, Seth mentioned doing recruitment maneuvers on the ventilator. It's complicated. We can do it. I'll be honest, I don't even know if we can do it with the Hamiltons. I don't know if we can do it with the Revels, but our RTs can certainly do it with a ventilator that a patient is on in another intensive care unit. And let's see, Seth also mentioned, clamping ET tube. Yeah, so that's a really important point. It was actually in one of those slides, but I forgot to get to it. Preventing de-recruitment is a really critical step. And the 2 times that you de-recruit folks are switching them from their vent to our vent, or BVM to a vent is going to de-recruit them, or taking them off the ventilator or the BVM to suction them will de-recruit them. So I think this is really critical. If you're going to switch them from a vent to vent, clamp the endotracheal tube with that clamp that's in the vent bag now, or in the interfacility bag, anytime you do a disconnect. And it's really important to use that inline suction to suction these folks. So when you set up your ventilator, make sure you put the inline suction in it so you can maintain PEEP while you're suctioning them to prevent de-recruitment. And let's see, Brett commented, you can use CPAP with pressure support and PEEP to set the PEEP to 20. Yeah, that's also a good strategy. Although if you're requiring PEEP as high as 20 for somebody with spontaneous ventilation and using pressure support or using pressure support ventilation, I'll venture to say the patient's probably getting too tired, or they're at significant risk of being tired and fatigue contributing to their respiratory failure, and probably better to sedate them and paralyze them and let the ventilator do the work for them.
Dr. Bott, sorry to step on you. That's in reference only to a recruitment maneuver. I've done that with medical ICU attendings in the past. That simply just prevents the ventilator from providing a breath above that PEEP, so we avoid any sort of trauma. That's only for the recruitment maneuver.
I gotcha. If you're using the ventilator to do the recruitment. Yes. That's why I didn't want to go into that. It's pretty complicated. Ray says, yeah, the recruitment maneuvers with our vents are pretty close to impossible. And yeah, there's a couple of other comments from Brett and Ray on there. Yeah, Ravel not capable to do recruitment maneuvers. That's a mouthful. I know these patients are really difficult to manage, and the ventilator management is really complicated. You guys are doing an awesome job so far with these folks. I hope this helps fill in a few of the gaps. Please take the opportunity, nurses, while you're in the COVID ICU, to get the RTs up there. Ask the RT, who is in the ICU with the worst ARDS? Show me how you're managing their ventilator. It's a great training opportunity for you guys, because so many of those folks have got this bad ARDS. Any other questions I can knock out before we move on to our case presentations? Bryson says, is there an appropriate time to clamp the tube? Oh, that's a great question, Bryson. The best time to do it is at the end, is at full inspiration. So you're clamping the tube while their lungs are completely full. If you do it while they're in an expiratory phase, at least you're maintaining that high PEEP instead of room air pressure. But even better yet is to do it while their lungs are completely full. But bear in mind that high pressure is going to really impede their venous return. Their blood pressure may tank when you're doing that. So make sure you're making that transition really quickly. And obviously it's going to be really uncomfortable for the patient. So make sure they're adequately sedated and paralyzed.
Dr. Bott, another question to piggyback on that. What is the risk of, say, pneumothorax during that maneuver if the patient's not adequately sedated and paralyzed?
The risk of pneumothorax is really significant for all of these patients, even without doing that. High vent pressures have significant risk for pneumothorax, and that pneumothorax would quickly turn into a tension pneumothorax. And how do you tell a tension pneumothorax when they've already got vent pressures of 50/20? Ultrasound or chest x-ray. All right, anybody else? All right, my hat's off to you guys. I know these are really challenging patients to manage, even without considering all the PPE stuff you're dealing with. I'm super proud of the way you guys are doing it, and keep up the good work.